Good afternoon, everyone. Today I am going to discuss about hospital antibiotic stewardship program. So for the next 1 hour, I'll be talking about goals of the antimicrobial stewardship program, identify the stewardship technique, list steps for starting a stewardship program, and to identify the potential barriers to implementation of stewardship program. So just to start with, why do we need antimicrobial stewardship program? In the early days of antibiotics, that is from 1935 to 2003, we used to call it as golden age of antibiotic discovery. 14 new classes of antibiotics were introduced. This was the era of booming drug development, meant that even when resistance developed for one antibiotic, there used to be a new antibiotic available for treatment of drug-resistant bacteria. So very effective, safe and relatively inexpensive antibiotics, which used to save millions of lives, used to be available in those days. However, this has led to their overuse, misuse in humans, animals, and in other sectors. So globally, between 2000 and 2010, there has been a massive rise in overall antimicrobial consumption, largely as a consequence of uncontrolled prescription over all the counterparts of the world. So this is the new CDC data showing that unnecessary antimicrobial therapy was there in all the sectors of the phase. So antibiotic prescribing was not supported in 79% of the patients with community acquired pneumonia. It means that here, no? Sorry for the disturbance. So this is the recent data for new CDC data, which shows that antibiotic prescribing was not supported in 79% of the patients with community acquired pneumonia, and 77% of the patients with urinary tract infection, and 47% of the patients prescribed fluoroquinolones unnecessarily, and 27% of the patients were on the IV vancomycin therapy unnecessarily. So yet since 1998, only 10 new antibiotics have been reported, out of which only two have been approved, and which have only new targets of action. The reason for this is very simple. Drug development is risky and expensive, and whenever the new drug is developed, within few years of using it, misusing it, irrational using it, it's getting drug resistant. So during the last 30 years, antibiotic development have slowed considerably, and our options for treating increasingly resistant infections are becoming more and more limited. This is called discovery void of pharmaceuticals, which resulted in increase in antimicrobial exposure because of misdosing, misduration, and different types of antibiotics. Selective pressure was seen in antibiotics in the drug-resistant bacteria. So in this slide, we can see large population of bacteria initially susceptible to the drug becoming resistant, and the same thing is spread to the other bacteria in the form of plasmids and drug resistant, and DNA, which is resulting in resistant bacteria spread throughout the hospital as hospital-acquired infections, which the hospitals are struggling to prevent the infection. So commonly known pathogens like escape pathogens, E stands for Enterococcus faecium, S stands for Staphylococcus aureus, K for Klebsiella pneumonia, Acinetobacter, Pseudomonas, Enterobacter species are leading cause of nosocomial infection nowadays. Out of which, Klebsiella pneumonia has the highest resistance, and it's showing resistance to all the group of antibiotics, which is causing a worldwide problem in which clinicians have fewer antibiotic treatment options for treating hospital-acquired infections. So this increasing level of antibiotic resistance is now a global problem and resulting in higher morbidity, higher mortality, and prolonged length of the stay for the patients. So have we reached the end of the road for treating the infectious cases? Everyone should stand up and realize that antimicrobial stewardship program have to be implemented right now, because the review on antimicrobial resistance estimates that unless action is taken, the global burden of the deaths from antimicrobial resistance could balloon to 10 million lives every year by 2050. So why do we need antimicrobial stewardship? So now more to optimize the use of antibiotics, prevent the development of resistance, and to prevent and to improve the patient's outcome. So the two main definitions to understand the AMS is at systemic level, antimicrobial stewardship is an organizational or healthcare system-wide approach to prompting and monitoring judicial use of antimicrobials to preserve it further effectiveness. At individual or team level, AMS is an interprofessional effort across the continuum of care, involves timely and optimal selection, dose and duration of an antimicrobial for the best clinical outcome with minimal toxicity and with minimal impact on the resistant patterns. So let's discuss about the goals of the antimicrobial stewardship. There are three major goals. First goal is to work with healthcare practitioners to help each patient receive the most appropriate antimicrobial with correct dose and duration. The 4 Ds of optimal antimicrobial therapy are right drug, right dose, de-escalation to pathogen-directed therapy, and right for right duration of therapy. The second goal is to prevent antimicrobial overuse, misuse, and abuse. In both the hospital and outpatient settings, antibiotics are given to the patients with viral infections, non-infectious processes like febrile patients with pancreatitis, bacterial infections that do not require antibiotics like very small abscesses which normally resolve with incision and drainage, and treating of bacterial colonization, so patients with Foley's catheters, and the use of broad-spectrum antibiotics that cover the multitude of organisms in patients whose infections are acquired in the community. Failure to adjust antibiotics according to the culture data. These are the most common irrational causes for irrational use of antibiotics. And coming to the abuse of antibiotics is more difficult to define, but term might be used to describe the use of one particular antibiotic preferably over the other by a physician or as a result of aggressive detailing by the pharmaceutical representatives. And the third goal is to minimize the resistance of antibiotics. So to fight to the end of resistance starts now. As a clinician, you can play a key role in reducing antibiotic resistance pattern by following strictly the antimicrobial stewardship program. It is possible to end the antibiotic resistance crisis if hospitals and clinicians take an active role in this. So coming to the core elements of hospital antimicrobial stewardship program, it includes strong hospital leadership commitment with accountability and a strong pharmacy expertise with a planned action followed by tracking, reporting, and education. Coming to the hospital leadership commitment, it is very crucial to the success of AMS. So it needs a strong support from the senior leadership of the hospital, especially Chief Medical Officer, Chief Nursing Officer, and Director of the Pharmacy. A lack of necessary resources from this hospital leadership commitment is one of the top most barriers for the success of stewardship program. So hospital leadership commitment can give support to the other team members by giving time to the stewardship interventions, by giving sufficient resources like staffing for commencing the program, and by having a regular meetings and appointing a champion for stewardship program so that he can help to ensure that the program has resources and perfect support, and reporting the stewardship activities and outcomes to the leadership. At the same time, key support from the clinicians as well as department of program heads is also needed, as clinicians are one of the largest prescribers of the antibiotics in the hospital. They also often have experience in quality and improvement work. It is vital that all the clinicians are fully engaged in an AMS program. And from the pharmacy department, pharmacy and therapeutic committee can play a key role in helping to develop and implement policies that will improve the antibiotic use. Hospital infection prevention. Clinicians and hospital epidemiologists can also assist with educating the staff and analyzing the data of antibiotic resistance. Even microbiology laboratory staff can help in getting the data like antibiograms, helping guiding us for the proper use of test and follow up of the results. Again, they can help us in guiding us a rapid diagnostic test and breakup points for antibiotic susceptibility testing, which helps us in guiding the antibiotic therapy. Even IT staff has a crucial role in implementing the antimicrobial stewardship program. So they can make up the protocols in the form of setting orders, access to the facility and specific guidelines. And nurses also have a key role in the antimicrobial stewardship program. For example, nurses can inform patient about whether or not the patient has symptoms that might justify a culture, ensuring that cultures are performed correctly before starting of antimicrobial therapy, prompting discussion of antibiotic treatment, indication, duration, and evaluation of any drug allergens. So thus, we can start off with a small antimicrobial stewardship team, including identification or affiliation with a pharmacist, in collaboration with the microbiology laboratory, hospital epidemiology, and a strong administrative department. So pharmacy expertise is a must. A pharmacy person, he is infectious disease trained, it would be better. Or a normal general clinical pharmacist are more effective when they have been trained on the antimicrobial stewardship program. So then putting our action into plan. Before putting our action into plan, we need to initially assess our own hospital antibiotic prescribing patterns and to identify what outcome data we need to get from the prescribing patterns, such as prescriber satisfaction, antimicrobial usage, expenditure, clinical outcome variables, conversion from IV to oral administration for selected highly bioavailable antimicrobials, cessation of perioperative prophylaxis within 24 hours for clean contaminated surgeries, consultation with the ID physician before continuing the administration of selected drugs beyond 48 hours. So before starting the anti-AMS team, we need to understand our hospital antiviral as well as pathogen most commonly involved pathogen in our hospital. So coming to the interventions that we shall implement in AMS there are mainly two main interventions. So first one is pre-authorization, otherwise we call it as front-end or pre-prescription approach. Second one is prospective audit and feedback, otherwise we call it as back-end or post-prescription audit. Pre-prescription or front-end or pre-authorization approach. So here, this is a restrictive prescriptive authority. Certain antimicrobials are considered restrictive in this method. Require prior authorization for use by all the except a selected group of clinicians. So clinicians without authority to prescribe the drug in question must contact the designated antimicrobial stewardship before obtaining the approval for the microbial. So we can prepare our own antibiotic restriction form. It's commonly antimicrobials which we wanted to keep it under restriction antibiotic. This is the form we are using in our hospital. So this is commonly filled by our pharmacist. Consultant prescriber will be filling this. This is a justification form. So the need for the antibiotic is commonly ticked here as whether the drug is used as prophylaxis, empirical or documented. Here it is documented by the patient. Site of infection as a suspected pathogen is also filled by the consultant or the prescriber. And the reason for prescribing the antibiotic is also filled. This justification is signed by the prescriber and it is sent to the antibiotic stewardship team for authentication. So advantages of this method is target specific antimicrobials for specific indication based on local restricted patterns and formulary are used. Antimicrobials can be approved for specific duration, thereby prompting review after culture data has been obtained. There will be a significant reduction in expenditure of the targeted drug. Coming to the next method, that is prospective audit and feedback, otherwise called back-end or post-prescription approach. Here, the antimicrobial steward reviews the current antimicrobial orders and provides the clinician with recommendations to continue, adjust, change, or discontinue the therapy. So, based on the antimicrobial results, he will be suggesting the prescriber about these indications. So, studies of the program that use this approach have shown decreased antimicrobial use, decreased number of new prescriptions of antimicrobes, and improved clinician satisfaction. The effectiveness of prospective audit and feedback can be enhanced by providing feedback to the provider by face-to-face meeting or with handshake stewardship in the meeting. So these are the forms that we use in our hospital. These are filled by the clinical pharmacologist. So these are columns, the dedicated columns for the diagnosis, as well as columns for filling the culture data, as well as columns to fill the drug data. So here in this form, with this form, we will be able to assess whether the drugs are being delivered in the right dose, right duration, right time. And this form is forwarded to the Antimicrobial Stewardship Committee for the rationality of use. So back-end approach advantages to focus, especially this focus on de-escalation, a critical aspect of antimicrobial use. De-escalation is modification of initial empirical antimicrobial regimen used on culture data, other laboratory tests, and clinical status of the patient. And de-escalation includes changing a broad spectrum antibiotic to one with narrow coverage, changing from combined therapy to monotherapy, or stopping antimicrobial therapy altogether as it becomes more apparent these drugs are not needed. So this is the common chart showing the both front and back end. Front end strategy is a common chart. So there are some more interventions which can be followed by the pharmacy department. They can put these interventions as a quality indicators. So that is documentation of indication for antibiotics, automatic changes from IV to orals, dose adjustments, especially in renal failures or therapeutic drug monitoring is needed. Dose optimization in case, especially in critically ill patients where drug-resistant bacteria are involved, and duplication therapy alerts where multiple antibiotics with same spectra are involved. Time-sensitive antibiotic stop orders for pre-operative surgical prophylaxis, detection and prevention of antibiotic-resistant drug-drug interactions. Some of the microbiology-based interventions are selective reporting of the antimicrobial testing results. So tailoring of hospital susceptibility reports to show the antibiotics that are consistent with hospital treatment guidelines. And comments in the microbiology report can help the clinician to decide on the correlation or contamination of the specimen. So and these rapid molecular methods also help in de-escalation of the antibiotics. So like peptide-based nucleic acid technologies like PCRs, which can be done with the positive blood cultures, and the reports will be available within 90 minutes. Matrix-assisted laser reabsorption ionization technology. So here also blood culture positive culture specimen can be submitted and the reports can be obtained within 60 minutes. This type of, if these facilities are available, then the de-escalation process will be very helpful for the clinician. And some more nursing-based interventions like bedside nurses often initiate the following interventions: optimizing the microbial cultures because proper techniques are necessary before collecting the cultures, and switching to intravenous to oral therapies, and antibiotic timeouts. Nurses often know how long a patient has been receiving antibiotic and when the laboratory reports are available. They can play a key role in prompting reevaluation of the therapy at a specific times, such as after 2 days of treatment when the culture results are available. So once the interventions are made, it is very necessary to track the results So measurement of antibiotic stewardship interventions may involve evaluation of both the process and outcomes. So this can be done with two quality indicators like antibiotic use measures and DDDs. And days of therapy are the sum of the days for which any antibiotic of a specific antibiotic agent is administered to the patient. This we can get it from the antibiotic use measures. DDDs. DDD estimates antibiotic use in hospitals by aggregating the total number of grams of each antibiotic purchased, ordered, dispensed, and administered during a period of interest divided by WHO assigned DDDs. So we can keep a benchmark for these two indicators and assess our interventions. Even hospital antibiogram will help us in knowing the most common pathogen and resistance patterns of our hospital. So finally, after tracking, reporting is also very important. Summary information on antibiotic use and resistance along with antimicrobial stewardship program work should be shared regularly with the leadership program as well as board on the processes and outcome measures, and it should be shared with the prescribers, pharmacists, nurse and leadership team. So finally, education should include case-based education in the form of posters, flyers, newsletters, or electronic communication to all the staff, and feedback to the consultant through the handshake stewardship program. Where can things go wrong, like pitfalls? One of the greatest challenges of antimicrobial stewardship research is demonstrating a clear causal relationship between AMS and decreased rates of antimicrobial resistance. So this is one study showing squeezing the balloon. This is an example of squeezing the balloon phenomenon in which the decreasing of one antimicrobial use or class results in increasing use of another, often with associated resistance. So studies of outbreak of Clostridium difficile infection have shown improvement in infection rates with decreased use of cephalosporins and fluoroquinolones. So this is my final chart showing the antimicrobial stewardship algorithm with the goal as right drug, right dose, right time, right duration for every patient. Start smart. Do not start antibiotic in the absence of clinical evidence of bacterial infection. Take history of relevant allergies. Initiate prompt effective antimicrobial treatment within 1 hour of diagnosis. Compare with local prescribing guidelines. Document clinical indication and dose on the drug chart. Include review of stop dates and duration. Ensure relevant microbial specimen taken. After 48 hours, review the cultures and we can stop based on the microbial culture report or IV to oral switch or change to narrow spectrum antibiotic or continue based on the culture report. So my take home message would be just remember about the MINDLY. M stands for microbiology guided therapy wherever possible. I indication should be evidence based. Narrow spectrum is required. Dosage appropriate to the site and type of infection. Minimize duration of therapy. Ensure monotherapy in most of the cases. Thank you for giving this opportunity for educating the antimicrobial stewardship program and what we have been following in Apollo hospitals. Any questions, please?